Good afternoon, everyone. Am I audible?
Yes, ma'am.
Okay. Sorry, it got delayed due to some technical issues. So let's start the class. So today's topic is from pediatrics, history taking in pediatrics. So the three pillars of evaluation of a patient, even if the patient is in the OPD, patient is in the IP or over phone, it is like history, the first pillar. Then clinical examination and investigation are the supplementary pillars that help in evaluation of the patient, and then that will lead to a diagnosis and further management of the patient. So what is the role of history? History will identify the pattern of the common disease. It's like if the patient is having fever, headache, and vomiting, you will suspect meningitis. If the patient is having a contact with COVID-19 and now having a fever, you may suspect COVID. It's like you will identify the pattern of common diseases. So most of the diseases present in pattern, identifying this pattern will lead to diagnosis of common cases. And clues from history lead to clinical examination finding. Like I said earlier, if the patient is having headache, vomiting, and fever, when you suspect meningitis, you will examine for neck stiffness and then lead to investigation. The history, the clues will lead to the investigation. For you people, the important is in presenting a case in class. I don't know whether you have started seeing cases for passing obviously MBBS examination. In your house urgency, you will separately, you will be in charge of a patient and you will have to take OPD ward management. You have to take history of the patient and decide on the management, and then for practice obviously after everything. Before going to history, you should be knowing how to take a proper history. There is a structured way by which you should be taking case history or assessment. That include the first part is identifying the patient demographic. Then you will be taking history of presenting complaint, then past illness and other conditions. For pediatrics, you will be taking antenatal, birth history, and postnatal history. This is different from what you take in medicine. Then comes the development history, immunization history, dietary history, family history, and social history. Now, in following classes, you will be taught about development history, immunization, and diet history separately. So I won't be dealing with these topics in details. So we will see the other parts like history of presenting complaint, past illness, antenatal, postnatal histories, family history, and social history. So the important thing is to when and where and how to take a history. So before taking a history or before doing examination and everything, you have to introduce yourself as I'm this one, I'm studying in this semester and I'm doing this house urgency, or like you have to introduce yourself. You should be child friendly and also the informant friendly. You should bring toys, chocolate, age appropriate communication has to be done with the patient. Baby talking won't be tolerated by adolescents. You should be knowing all these things. And the informant you should ask the informant to sit. If the patient is calm or it's crying aloud and all, the mother won't be able to give you a proper history. So you should ensure the child is calm. Either you should make the child calm by giving toys, chocolate, and all, or you have to send the child with another bystander. And you should be friendly. Should maintain eye contact. It's like the basic communication skills you should have, and you should follow the structured approach. I have already shown you which way you have to follow the structured approach. Now the first part is the demographic, like the child's name, age, sex, address, nationality, ethnicity, and relation of the informant, and date and time of the interview or admission has to be noted properly. Then comes the questions. To elicit the proper history, you should be asking questions. The questions include in three pattern of questions are like open questions. It's like, tell me more about the pain. It's like encouraging the patient to talk. It's very useful to start a conversation and find out what is going on. Direct questions are like specific piece of information. What have you ate today in the morning? Like that questions. Like leading questions are isn't it questions. It's like, am I audible? Is there any problem? Okay. Leading questions or isn't it questions are usually, they are not encouraged. Even if you are supposed to you have asked a leading question and the patient has said, or the informant had said yes or no answer, you have to always cross verify. If you don't ask the right question, you won't get the right answers. So you have to remember, like the parent or patient may not be knowing what to tell you. You have to elicit the history. It's not like the parent or the patient will tell you that what you needed. It may be due to ignorance or it may be due to nervousness. The medical terms or common terms may have different meaning for the patient. For example, in our area, patient may complain of, or the mother may tell you the patient is having funny. The funny term usually is translated to fever. But in some areas, even URI, upper respiratory tract infection, nasal block is referred to as funny. So you should confirm these terms or the common terms used are meaning it's medically correct or not. Or it's like basic communication. Do not show dissatisfaction. It is, or you are not there to judge or comment. You are there to learn from them. So always remember that. Now, about the presenting complaint, this is the first step after demographic. You have to, the presenting complaint may be a symptom. It's like the patient may be having a headache, patient may be having a fever, patient may be having a diarrhea, or a sign, or there is maybe a lump, or there may be a skin rash or any sun, or patient may be admitted for an abnormal laboratory test. Patient was seen in an OPD basis and found to have raised ESR or a abnormal LFT. That's why the patient may be admitted. That will become the presenting complaint. No, you have to note the duration, and in details, you have to evaluate the presenting complaint, and that has to be done in chronological order. What is the chronological order? It should be, it's like a 5-year-old child was presented with one episode of seizure, and hence admitted. What will be the presenting complaint like? The main presenting complaint will be seizure. The patient, but on asking, the patient may tell he had fever for 2 days, fever for 3 days, headache for 2 days, vomiting for 2 days. So in chronological order, you have to write like the patient presented with fever for 3 days, headache for 2 days, vomiting for 2 days, and one episode of seizure 1 day back. So it's like you have to get a timeline of what is happening to the patient. It's the chronological order. So whenever you get a complaint, it may be fever, it may be headache, whatever it is, you have to ask few characteristics of these complaints and explain. It's like the time of onset, it's the exact time, it's in the morning, it's in the night, or it's in the evening. You have to ask this. Then the mode of onset, the headache may be rapid onset, as you know, it's in subarachnoid hemorrhage, etc. The headache is very sharp in onset. The onset is very rapid, or maybe gradual, very chronic in onset, especially in case of intracerebral space occupying lesions. It's very gradual in onset. And the characteristic severity, frequency of pain, or whatever complaint you are describing, it may be abdominal pain, it may be headache, it may be fever. You have to describe the characteristics, severity, and frequency. Some disease, progression of illness, duration of illness, any precipitating or relieving factors, associated symptoms, predicted complication, therapy, investigation, which are done till now, and the current should be described in detail. These by just asking the patient to predict the complication. Like if you know the patient is having edema and a patient is having a protein of urine, you will know that the patient is having a nephrotic syndrome. If you know about nephrotic syndrome, then only you will be knowing that the predicted complications are like acute kidney injury, cerebral venous sinus thrombosis, or the patient may get spontaneous bacterial peritonitis. So we should be knowing something about the subject. Then only you will be able to know the predicted complication. If the patient is having edema, it's like a nephrotic syndrome complication. You should know about complication, like pertinent data. If as 12-year-old girl is presenting to you with nephrotic syndrome, the negative data that you should be asking is like whether she is having HSP or whether she is having SLE. It's like the rashes in the legs or joint pain, facial rashes, photosensitivity. You will be asking only if you know the subject. So most of the things can be asked even when you don't know in detail about the subject. And in detail, only if you know in detail about the subject, you will be able to elicit the most important negative data or the complications. At the end of the history taking, you have to state the current status of the patient also. This is about every complaint. You have to describe every complaint in detail. Under these terms. Then after getting the data from the patient, you have to at least do a system review. You have to, if there are any general complaints like fever, rashes, headache, is there any respiratory complaints? Patient may not be telling you, but you have to elicit by just asking negative history. Is there any ENT complaints? Cardiovascular, you will know the major, what the clinical complaints that I will show you the slides. Gastrointestinal, genitourinary, at least you have to ask the basic symptoms or signs. Then at last, after taking a presenting illness, you should including along with that, you have to address the patient parents' ideas. What is the concern, main concern of the patient? Patient maybe, or what are the expectations they are having by coming to you in the OPD? or while they are admitted. At the end, you should be knowing what is happening to the patient, what's the main complaint, what is the extent of the condition, what is the probable etiology to be considered. You have to come to this etiology by taking a positive and negative history. Sometimes you won't get a definite diagnosis, you may get a differential diagnosis. The patient is having an edema and there is no jaundice, no frothing of urine. You may be having a diagnosis, a final diagnosis after the history, then you will have to go to clinical examination or investigations. After the presenting illness, next part is the past illness. You have to elicit any significant medical, surgical, or allergic history. Then the important thing is antenatal, postnatal, and postnatal or birth history. Then the antenatal history, it's like the gynec case taking. You have to get the prenatal history, whether mother's age, pregnancy, whether it is planned or not, folic acid taken or not, what was the previous pregnancy outcome, diet of the mother, whether she's alcoholic, smoking, was there any problem or illness during the pregnancy, you have to ask. Just like the gynec case taking, first trimester, you have to ask the radiation, fever, rash, drug, or infection. Second trimester, you have when was thickening noted. Was there any ultrasound abnormalities? In the third trimester, you have to ask about the fetal movements, ultrasound findings, or infections, or has she taken drugs which were supposed to be taken. You should be knowing about the effect of some teratogenic drugs. Most of these are anticonvulsants like valproate, carbamazepine, phenytoin, AC. The list is extensive. Then in the natal history, where you should be knowing, whatever you ask in your gynecology posting, that should be described in the natal history also. What was the mode of delivery? What was the presentation of the fetus? Was there any complication during labor? Was there any peripartum rupture of membrane or maternal fever that indicate fetal infections also? In the birth and the postnatal history, did the baby cry soon after birth? Was there any resuscitation needed? What was the date of birth, birth weight? What were the gas scores? And when was the feeding initiated? When did the baby pass meconium and urine? Was there any NICU stay and the indication for NICU stay? And immediate postpartum, you have to ask about cyanosis, jaundice. These are the complications that usually seen in the NICU. Jaundice, seizures, respiratory distress, infection, any congenital anomalies or birth injuries noted that time. All these has to be asked in detail. After this natal history, we will go to family history. This is usual. This is common to what we take in medicine also. So you have to take parents' history. What was the age of the parents? What is the age of the parents? What is the consanguinity? Number and age, sex, or any medical illness in the family, in the parents or a sibling, or any history of death among parents or sibling, illnesses that is running in the family, and diseases that affect more than one member of the family, or any particular illnesses affecting the parents or siblings should be noted in detail. And you have to make a pedigree chart. Pedigree, it's like the circle is denoting a normal female and the square denotes the normal male. The line, I don't know. This line denotes meeting, and two lines together added is like consanguineous mating. This consanguinity can be first degree, second degree, or third degree. The first degree, it's like parents, siblings, it's like incest only. Second degree is with uncles, aunts, nephews, nieces, grandparents, or grandchildren. And the third degree that usually we see here is marrying a first cousin. great grandparents or great grandchildren. From the inherited, usually the metabolic diseases commonly inherited as autosomal recessive. If one of the parents are involved, then most likely it is autosomal dominant. There are exceptions. If the parents are not involved and the siblings are affected, the inheritance you will consider as autosomal recessive. And parents or siblings both are involved, since there is 50% chance of sharing, likely it is autosomal dominant. If the affected patient is a boy and the maternal uncle is involved or the maternal aunt children are involved, then most likely the inheritance is X-linked. There is an issue with the penetrance. Penetrance is like you are having an abnormal gene, but it is not expressed. It's like you are having an autosomal dominant polycystic kidney disease. It is autosomal dominantly inherited. If the parent is having, it's not necessary that the parent should express it or parent should express the clinical features. So that means penetrance may affect these kind of prediction by family, if the family is involved. Then comes the social history. Social history, usually we use the Kuppuswamy scale. Here we assess it's from 1976 and it is modified subsequently. We will assess some characteristic of the head of the family and we will divide into upper class, upper middle class, lower middle class, upper lower class, lower socioeconomic class. The education of the family, there is some scoring. Occupation of the head of the family, sorry. There are some scoring and income that changes at least every 2 to 3 years. These income changes, and according to this, total score is calculated. And according to the total score, we put into various categories, whether it is upper class or lower class. This total score determines the categories. So we have come to the end of history taking in detail. Do you have any questions to ask? Is there any doubts or questions? Am I audible?
Yes, ma'am.
No questions. Let's proceed. Okay. Now I've already told you have to ask some general complaints like fever, rash, system you have to follow, and the main symptoms I'm going to tell next. General breathlessness, nasal discharge, hemoptysis, wheezing, grunting, or chest pain. Cardiovascular, the main symptoms are dyspnea, palpitation, chest pain, cyanosis, cough, or edema. On the gastrointestinal tract, the main complaints are abdominal pain, diarrhea, vomiting, constipation, hematophagia, jaundice. Central nervous system, the main complaints include seizure, paralysis, altered sensorium, focal deficit, headache, vomiting. The genitourinary system, most complaints are like dysuria, hematuria, or edema. When the hematological system is affected, the complaints include excessive tiredness, skin bleeds, joint bleeds, or recurrent infection. It's like when we are discussing a common case like breathlessness, you have to ask, as I have already told you, onset, duration, timing, severity, frequency, the aggravating, relieving factors, and associated symptoms. Like a few scenarios, if a 6-month-old boy presented with breathlessness for 2 days with low-grade fever, most probably you have to assess in detail, but most probably the respiratory system is affected, and the etiology may be a bronchopneumonia or a bronchiolitis. you should be knowing about the subject, and only you will be able to. Sorry, there is some overlap. The 2-year-old boy, while playing, suddenly present with breathlessness. It's again respiratory. Most likely, patient has aspirated something. 5-year-old child present with breathlessness, more at exertion. Okay. So there's a chance like it may be any system. It may be cardiovascular system. It may be respiratory system. It may be metabolic system. You have to evaluate in detail. If a 2-month-old, or I can read what is written. There is some overlap. So if the patient 2-month-old presented with suppressed cycle and head sweating, so most likely the patient is having some cardiac illness. The presentation of cardiac failure is typically present in infants like that only. If a patient present with history of early morning cough and breathlessness, likely system involved is respiratory system, and the diagnosis is asthma. An 11-year-old boy present with diabetes with breathlessness, and he also has a history of missing insulin. The fast breathing or dyspnea noted by the parents will be due to acidosis, and the patient may be having diabetic ketoacidosis. 12-year-old with tachypnea and carpopedal spasm. What is it? Tachypnea and carpopedal spasm is usually associated with the conversion disorder. The carpopedal spasm is due to hypocalcemia. It's not like true hypocalcemia. There is some, it's like false hypocalcemia. Common case like cyanosis, also you have to ask the duration, onset, timing, and location, which part of the body is affected. 4-month-old present with non-cardiac disease presented with breathlessness and worsening of cyanosis. It's like cyanotic heart disease. If patient is having breathlessness and worsening cyanosis with fever, you have to suspect a cyanotic spell. 1-year-old with pan-digital clubbing and cyanosis, it will be a CCHD. Cyanosis noted after anti-malaria. It may be a methemoglobinemia drug induced. 10-year-old patient with chronic lung disease presented with cyanosis after any onset fever, it's respiratory. You have to know which system is affected, then go to details. You about cough also, it can be respiratory, cardiac, allergic, infections of various sorts. So some may give you some history, few may give you a clue. It's like paroxysmal cough, or cough is a whoop gives respiratory localization. Maybe it's a whooping cough or a typical pneumonia. Precipitation by precipitated cough by allergens be allergic cough, and exertional cough, or maybe most can be cardiac or respiratory. In seizure also, you have to note whether it is generalized or partial in onset. Was there any bladder or bladder emptying? Was there any post-seizure confusion to note whether it is a true seizure or not? Whether you have to note whether fever, headache, vomiting, or photophobia, which may suggest a raised intracranial tension with fever may suggest an infection. Was there any history of seizures? Whether this is a seizure disorder where seizure was precipitated by some events, or was there any history of skipping medication? There was any trauma or perinatal, the history of perinatal depression may suggest patient may be having a seizure disorder due to structural or due to a scar in brain. Loss of consciousness is a vague term. It can be seizure, vertigo. The term used in our locality is like talagarakam. It can be loss of consciousness, it can be vertigo, it can be seizure. So you have to ask in detail. You have to ask about the involuntary bowel bladder emptying. It is specifically asked whether it is vertigo, and you have to ask the onset setting, etc. Fever, you have to ask the pattern. You know, this is continued fever, intermittent fever, skin fever, remittent fever, which is the pattern of fever. Whether it is high grade, low grade, what is the activity of the child in the interrectal period, and the associated symptom. It may be due to infection of any sort, inflammation, or even CNS cause can produce fever. So we have come to the end of the class. You can ask, I haven't covered the immunization history, development history, or dietary history, as you all have separate classes. You have, is there any question or any doubts you can ask? Dr. Aparna,
Yes, ma'am.
is there any question or comments or any doubts, or you all clear? So we can end the class.
It was clear, ma'am.
Okay. Then good. Thank you.
Thank you, ma'am.
Hello?
ആ പ്രൊഫൈലിൽ പ്രൊഫൈലിന്റെ
Hello, good afternoon. Hello.
Hello.
Hello, good afternoon. Can you hear me?
Yes, sir. ഞാൻ പോയതാട്ടാ. ഞങ്ങൾ 1 മണിക്കൂർ കഴിഞ്ഞ് വരാം. 1 മണിക്കൂർ കഴിഞ്ഞ് വരാം. ആരെ?
Hello. Hope everybody is present.
Hello. Hello.
Can you hear me? Can you hear me?
Yes, sir.
Hello?
Hello, sir.
Anybody? Can you hear me?
Good afternoon, sir. Hello, sir.
Good afternoon, good afternoon, good afternoon. Hope everybody is present.
Yes, sir.
Yes, sir. Can we start?
Yes, sir.
Okay, today's topic is, actually, I can't see any of you. Nobody is on the screen. Somebody, the class rep? Mr. Abdullah. Where is he? Hello. Okay, okay. Okay, shall we start now? So today's topic is hip dislocation and fracture shaft of femur. Isn't it? Am I right?
Yes, sir.
Yes, okay. So I'm going to share the screen now. Can you see the screen?
Yes, sir.
Okay. So first topic is hip dislocation. A dislocation means separation of the bones forming a joint. That is dislocation. There are two terms, subluxation and dislocation. So dislocation means complete separation of two bones, two or more bones that forming a joint. And subluxation means partial dislocation of, partial separation of the bones forming a joint. Can you see the screen? So today we are going to talk about hip dislocation. So you have to understand the anatomy of hip joint. Hip joint is formed by two bony parts. The first part is the head of the acetabulum. Head of the acetabulum is a globular structure which is found in the proximal part of the femur. And there is a socket called acetabulum which is present in the iliac bone of the pelvis. So acetabulum accommodates the head of the femur forming the hip joint. Then the hip joint is surrounded by capsule and which is surrounded by strong ligaments. One of the, actually the most strongest ligament of the body is present around the hip joint. That is called iliofemoral ligament. That is situated just anterior to the capsule of the hip joint. It is also called as Y ligament or ligament of Bigelow.
Excuse me,
It
sir.
was, hello, can you hear
Sir.
me?
Yes, sir. Sir, we cannot see the screen, sir.
You can't screen, you can't see.
No, sir.
1 minute. I was actually sharing. Can you see now? Hello?
Yes, sir.
Okay, we were talking about the hip joint anatomy. So hip joint is formed by the acetabulum, which is a depression in the pelvic bone, and the head of the femur, which is the proximal part of the femur, and which is surrounded by a capsule, and which in turn surrounded by strong ligaments. The strongest ligament in our body is called iliofemoral ligament, which is present on the anterior aspect of the hip joint. This ligament is also called as Y ligament or ligament of Bigelow. It was once asked as a MCQ in your PG entrance examinations. The strongest ligament in our body, that is iliofemoral ligament or ligament of Bigelow, or it is also known as Y ligament. Okay, the name Bigelow is important in hip dislocation, that I will tell you later. So, and around the hip joint, there are other structures, important structures. Posteriorly, there is one important structure, sciatic nerve, which you can see in the figure. There is an yellow string-like structure that run posteriorly, that is called sciatic nerve. Anteriorly, there are femoral vessels also. So this is the structure of hip joint. Now, types of dislocation of hip. There are mainly two types of dislocation. One is congenital and traumatic dislocation of hip. Today we are actually dealing with traumatic dislocation of hip. Congenital dislocation is a separate topic that will be taken later, or I think already it might have been taken. So congenital dislocation that usually present at birth, that we will deal later. Can you see the screen? Screen ഇടക്കിടക്ക് പോകുന്നുണ്ടല്ലോ. Can you see the screen? Hello?
Yes, sir.
Hello. So now we are talking about traumatic dislocation of the hip. What are the causes? Nowadays, due to the heavy industrialization and automobilization, RTAs are on the high. So the most important cause of hip dislocation is RTA, road traffic incident, and that too dashboard injuries are common. And another cause is fall from height. Fall from height also can cause dislocation, and fall on the side of the body, so that the trochanter is impacted, directly impact on the ground, and the head of the femur is driven into the acetabulum. The acetabular floor is fractured, and the head of the femur is driven into the pelvic cavity. That is also another type of dislocation. That is called central dislocation, that we will come to later. So these are the mechanism of injury, that is RTA, fall from height. In RTA, the dashboard injury is very important. You can see a picture of the dashboard injury here. The knee strike against the dashboard, and the force is transmitted along the femur to the head of the femur. So the head of the femur dislocate posteriorly. That is the commonest dislocation, dashboard injury dislocation. So what are the types of dislocation? If the head of the femur dislocates, so we say dislocation with reference to the head of the femur. If the head of the femur dislocates anteriorly with respect to the pelvis, it is called anterior dislocation of the hip. And if the head of the femur dislocates posteriorly with respect to the pelvis, it is called a posterior dislocation. And central dislocation, as I have already mentioned, the acetabular floor is fractured, and the head of the femur, acetabular floor is fractured, and the head of the femur is driven into the pelvic cavity. That is called central dislocation. And there is another variety of dislocation is fracture dislocation. Here, not only the dislocation is present, the head of the femur or either acetabulum or the head of the femur is fractured. That type of dislocations are called fracture dislocations. Here in this picture, you can see a posterior dislocation. Here the head of the femur is dislocated posteriorly. In the same figure, you can see a central dislocation also. Here you compare with the other side, the head of the femur is dislocated into the pelvic cavity. The second picture is central dislocation. The first picture is posterior dislocation of the femur. And this is fracture dislocation. Here you can see not only the head of the femur is completely separated from the acetabulum, it is dislocated out of the acetabulum, but also the head of the femur is fractured. These type of fractures where there is dislocation and also the fracture of the head of the femur. These type of dislocations are called Pipkin's fracture dislocations. Pipkin's fracture dislocation. There are 4 types of this Pipkin fracture dislocation that you need not study now. But for the sake of completion, I will tell. The type 1 Pipkin dislocation means here the head is dislocated and the head is fractured just below the ligament teres. You know, there is a ligament teres running from the center of the head of the femur to the acetabular floor. That is called a ligament teres. So there is a fovea capitis. There is a depression in the center of the head of the femur. That is called a fovea capitis. From the fovea capitis, a ligamentum teres runs from there to the floor of the acetabulum. So if a fracture, if a head of the femur fracture which is below the ligamentum teres, it is called as type 1 Pipkin dislocation. If the head of the femur fracture is above the ligamentum teres, that is above the fovea capitis, it is called type 2 fracture. And if there is head of the femur fracture along with the neck of the femur fracture, it is called type 3 Pipkin fracture dislocation. And if there is along with the fracture of the head of the femur, there is fracture of acetabulum, it is called type 4 fracture dislocation, Pipkin dislocation. So altogether you need know that there are mainly 4 kind of dislocations, out of which anterior dislocation, posterior dislocation, central dislocation, and fracture dislocations. Out of which posterior dislocation is the most commonest variety. Almost 60 to 80% of the hip dislocations are posterior dislocations. So now we will tell about the clinical features of the hip dislocation. First, posterior dislocation. So any dislocation, obviously, there will be severe pain. Actually, the pain in dislocation is severe than pain due to fracture. So any dislocation anywhere in the body, that will cause tremendous pain. So there will be pain and there will be swelling around that hip joint. There will be deformity and sometimes there will be numbness. Why there is numbness? Because most of the nerve structures, that is femoral nerve or sciatic nerve, these are present anterior and posterior to the hip joint. So if there is a dislocation of the hip joint, what will happen? The head of the femur is dislocated posteriorly. There is every chance that it will hit against the sciatic nerve, and sciatic nerve also displaced due to the stretching. It can cause numbness over the leg, that concerned leg. And the typical attitude, that is very important. As you can see in that picture, when the head is dislocated posteriorly, what will happen? There will be flexion of the hip, and there will be adduction of the hip, and there will be internal rotation. Because the head is dislocated posteriorly, the femur rotates internally, and a typical deformity that you can see when the patient comes to the clinic, you can see very evidently seen by seeing that deformity only, you can say that it is posterior dislocation. So the typical deformity, you should remember that flexion, adduction, and internal rotation. So typical deformity in posterior dislocation of hip is flexion, adduction, and internal rotation. Likewise, in anterior dislocation, the deformity is just the reverse. Flexion is the same. There will be flexion, and you can see in that picture, there will be adduction of the hip, and there will be external rotation of the hip. So in anterior dislocation, there will be flexion, abduction, and external rotation of the hip. and the pain, swelling, deformity, and numbness will be present there. In central dislocation, what happens? You may not be able to appreciate that much because the head is driven into the pelvic cavity by fracturing the acetabular floor. So there won't be that much deformity. The patient, the limb may be straight. The patient may keep the limb straight with slight flexion only, but there will be severe pain. So remember that any dislocation in the body, that is always an emergency, a dire emergency. Unless otherwise we are relocating or reducing the dislocation with immediate effect or within 6 hours, there will be every chance that there are a lot of complications. There may be necrosis, vascular necrosis. There may be some kinking of vessels and disruption of blood supply. Every hazard thing can happen. Now we are going into the investigation. Hello, Abdullah, can you hear me? Hello?
Yes, sir.
Can you hear me well?
Yes, sir.
Or the voice is little bit slumber?
No, sir, it is very clear, sir.
It's very clear. Okay. So, X-ray. The most important investigation we do in this case is X-ray. Or any orthopedic case, we do an X-ray. So, what are the things you have to look in that X-ray? Anyway, you have to compare the side with the opposite side. So you can see in that X-ray that in the one side it is the head is present normally in the acetabulum, the other side head is out of the acetabulum. That means the Shenden's line is broken. So there is a line called Shenden's line, which is formed by the inferior margin of the neck of the femur and the superior pubic ramus. That line should be continuous. That Shenden's line is broken here. So whether the you have to look for whether the head is out of the acetabulum, whether the Shenden's line is broken, and whether the here in this picture you can clearly see that the head is dislocated posteriorly. So which type of dislocation it is? By clinically you can definitely assess that. You can say that with by seeing the deformity. What the adduction, internal rotation, flexion. You can say that it is posterior dislocation. In X-ray also you can comment that, and always look for whether there any fracture present or not. Whether there is any fracture of the acetabular wall or fracture of the head of the femur. Always look for that. Now we will come to the treatment part. As I have already told you, it is a medical emergency. So as soon as possible, we'll have to reduce the dislocation. So there are two types of treatment method. One is the conservative method, that is called closed manipulative reduction. Here we are not doing any surgeries. Here we are manually reducing the fracture by applying traction. Okay. The other method is open reduction. When will we do open reduction? Most of the cases, in more than 80% of the cases, we will do closed manipulative reduction. That you might have already seen in our casualty or you will see eventually in your house urgency. But open reduction we perform only in some cases. If suppose even after closed manipulative reduction, the hip is unstable. That means hip is again redislocating. Then, and with multiple attempts, the hip is reducing, but again dislocating. In that case, we can do an open reduction. Usually, how it will happen? If there is a fracture of the wall of the acetabulum, posterior or anterior wall of the acetabulum, then what will happen? Even if it reduce the hip properly, because of there is no buttressing structure anteriorly or posteriorly, the hip will eventually dislocate. So in that case, we can do an open reduction and maybe internal fixation. Sometimes there will be intra-articular loose fragments. As I have already told you, it can be associated with head of the femur fracture. This fractured head of the femur is interposing between the acetabulum and the remaining part of the femur. Then it will be very difficult to reduce the fracture. In that case, we can do open reduction, internal fixation, and if there is a large acetabular fragment, so by looking in the X-ray, you can definitely say that even if we reduce it, then it will redislocate. In that case, so in 3 conditions, we can do open reduction internal fixation, failed closed manipulation. Second is if there is a loose fragment inside the acetabulum and there is a large acetabular fracture. In that cases, you can do open reduction and internal fixation. And about CMR, that is closed manipulatory reduction. How will you do a closed manipulatory reduction? There are so many methods. I have already described 4 methods, out of which I am going to elaborate only 2 methods. That is Bigelow's method and Stimson's method. There are so many methods. I will read the methods. One is Bigelow's method. Bigelow is one important figure in the field of orthopedics. Sir Henry Jacob Bigelow. His full name is Henry Jacob Bigelow. And Stimson's gravity method. Then Alice maneuver. Then Captain Morgan method, there Watson Johnson method. There are so many methods. So you just remember these 4 methods so that you can write in the exam. That is closed manipulatory reduction methods in hip joint dislocation. Bigelow's methods, Stimson's gravity methods, Alice maneuver, Captain Morgan's method. So I will tell a story about Bigelow. Actually, when he discovered the Bigelow's reduction method of posterior dislocation hip, he was just a house surgeon like you people. He was doing his internship in that famous medical college, and while he was walking along the floor, he saw a patient who was in severe pain, and he saw a professor walking away from that patient. Because professor walked away because at that time, it was in 1890s period. At that time, orthopedics was not that much developed, and they actually tried their best to reduce the fracture, reduce the dislocation. The professor and the crew tried their best, but it was not reducing. So Bigelow was an internee, house surgeon. He walked along the floor and saw that patient and asked the professor, "Sir, this is posterior dislocation hip. That is for sure because the typical deformity is there. There is adduction, internal rotation, and flexion is there. Why can't we do just the opposite to reduce the fracture? Means reduce the dislocation. Means if it is adducted, so we can abduct. It is internal rotated, so we can external rotate. It is flexed, so we can extend it. So there will be reduction." The professor actually doesn't like that. He scolded him, and the professor went to some other place. At that time, Bigelow, with the help of his colleague, he actually reduced the dislocation. What he does is he held the knee in 90 degree and applied traction along the line of the femur. And after applying traction, he slowly abducted and externally rotated the hip, then gradually extended it. Naturally, it reduced. After some time, professor happened to come along that way and saw that this patient, the hip is well reduced. The patient is out of pain. The patient is comfortable. So he asked somebody who has done that. So somebody named Bigelow. So he actually he should appreciate the Bigelow, but instead of that, he again scolded Bigelow. So in that range, the story goes like this: that Bigelow again redislocated it. So that is Bigelow's method of posterior dislocation or reduction of hip. Then Stimson's gravity method, as you can see, we will this method is done in prone position. The patient is lying along the edge of the table with both the thigh, both the legs are hanging out of the table. And in the case of posterior dislocation, we can just apply pressure over the hip, pressure over the posterior aspect of the hip anteriorly. Then you can reduce the posterior dislocation of hip. Hello, can you hear? Hello, can you hear?
Yes, sir.
Okay. So we have talked about the treatment methods also. Operative method, you need not study that much. You should know that there are operative methods. What are the indications for operative method? That I have already told you. Now come to the complications of the dislocation of hip. So as you know, sciatic nerve is situated or running along the posterior aspect of the hip joint. So there is every chance that there is a injury. There can be an injury in any severe RTA or posterior dislocation of the hip. So the most common injury to sciatic nerve is neuropraxia, because as the hip dislocate, the sciatic nerve is pressed and there will be a temporary cessation of the conduction of impulses. That is called neuropraxia. So axonotomesis sometimes can occur. That is a severe variety of injury. But neurotomesis means cutting of the nerve. That is rare. But if there is neuropraxia, the prognosis is very good. But if there is axonotomesis, then the prognosis is bad. Next is avascular necrosis. So how this avascular necrosis happens? Because the medial circumflex and lateral circumflex artery supplies the retinacular vessels, and sometimes due to kinking of these arteries, because of the dislocation, these arteries might kink and the blood supply to the head of the femur is usually cut off. And another thing is that another blood vessel is coming through the ligamentum teres. Ligamentum teres, anyways, it is always ruptured because of the dislocation, because it is connecting the acetabular floor to the head of the femur. This ligament is almost always ruptured in hip dislocation, but that supplies only minor, only 10 to 15% of the blood supply to the head of the femur. That doesn't matter that much, but the medial and lateral circumflex artery, especially the medial circumflex artery, kinking of that artery produces blood supply, loss of blood supply to the head of the femur, and eventually there will be avascular necrosis of the head of the femur. That can happen. That is the second complication. And osteoarthritis. Osteoarthritis can happen in any insult to joint, even if it is a sprain or joint fracture or a joint dislocation. Eventually, even after redislocating it, sometime later, maybe 3 or 4 or 5 years later, every chance that there will be some wear and tear of the joint. That is, and that will produce osteoarthritis. And another important complication is myositis ossificans. That may occur up to 10% of the population. This myositis ossificans is actually formation of newborn around the joint. So what will happen if there is a myositis ossificans in dislocation of hip? It will bridge the joint. The newborn formed will bridge the joint. It will form a bridge between the pelvis and the femur. So the patient will lose the movement. So it is also a grave complication. So it most commonly occur when in our Kerala and Indian places, what happens is that if there is injury, definitely the local people gather around and they will massage it. There will be a massaging section. This massaging section is actually hazardous to the patient. This massage will produce the organization of hematoma in the muscles around the hip joint, and that later ossifies to form myositis ossificans. So these are the main 4 important complication to the hip joint dislocation. So the crux is hip joint dislocation can happen due to RTA or fall from height. It is mainly 4 types: anterior, posterior, central dislocation, and the fracture dislocations. And the typical deformity in posterior dislocation of hip is flexion, adduction, internal rotation. The typical deformity in anterior dislocation of hip is flexion, abduction. Just the opposite of the posterior dislocation: flexion, abduction, and external rotation. And the central dislocation, the head is driven into the pelvic cavity. Then the screen has gone. That is okay. So the treatment is most commonly closed manipulative reduction, and sometimes operative, that is open reduction. Open reduction is indicated in case of failed closed manipulative reduction, or a loose fragment inside the acetabulum, or a large acetabular fracture. Then the complications are mainly injury to sciatic nerve, the myositis ossificans, avascular necrosis, and osteoarthritis. Now come to the next chapter. Next, that is fracture shaft of the femur. So you know that as I have already told why orthopedicians survive today because of the tremendous amount of RTS in the roads. So a lot of road traffic accidents occurring nowadays. So it can cause any type of injury. Previously, when the automobiles were less in the country, only minimal fractures were there because a fall from height can produce a simple fracture of the shaft of the femur. Nowadays, it is not the scenario. In RTA, it is a high velocity injury. It can produce almost any kind of fracture, open fracture, comminuted fracture, or segmental fracture, or whatever ugly fracture you can think of, it can happen in RTS. So so the etiology is mainly traumatic, and we can classify it into traumatic and pathologic. So traumatic, as I have already told you, RTA, trivial traumas in elderly, fall from height. So in elderly, usually most of the Indian population, almost after the age of 60, their bone strength is begun to lose. That is, they will become osteoporotic. So in osteoporotic bone, not much force is needed to break a bone. For a trivial fall, there can be a fracture. So in elderly, only trivial trauma is enough. But otherwise, fall from height or RTA is the majority of cases. The etiology and pathologic fractures are different kind of pathologies are there. Congenital fractures are there. For example, a child born with osteogenesis imperfecta. This child can have multiple fractures in later life. So you might have seen some patients with osteogenetic imperfecta. If you come to OPD, we will show that. Then neoplastic variety of pathologic fracture. Suppose if there is a neoplasm in the femur, just like osteosarcoma or your multiple myeloma in elderly, or Ewing sarcoma in young children, all this can produce a neoplastic pathologic fracture. And another is metabolic bone disease. For example, scurvy, rickets, all these are metabolic bone diseases, or Gaucher's disease. All these are metabolic bone diseases can produce fracture because of the loss of strength of femoral bone. So this is the etiology of fracture. So now we come to the pathoanatomy of femoral shaft fracture. Actually, the femur is divided into three regions. First is the trochanteric region. Trochanteric region where the greater trochanter, lesser trochanter is present, and trochanteric and subtrochanteric region. That is one region. Another region is the supracondylar region, which is just above the condyles, femoral condyles, and the shaft of the femur. So now we are talking about the femoral shaft fractures. So what can happen when there is a fracture in the shaft of the femur? There are, femur is surrounded by very strong muscles. There are external rotations are there, abductors, adductors, flexors. So many muscles are around the femur. So when there is a fracture, what happens to the proximal fragment? To the lesser trochanter, this iliopsoas is attached to the lesser trochanter, and abductors is attached to the greater trochanter. So what can happen? The iliopsoas are actually strong flexors of the hip. So the proximal fragment goes into flexion because of the action of the unopposed action of the iliopsoas. And the abductor, which is the abductor of the hip? Can you say, Abdullah? Which is the abductor of hip? Hello? 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 Hello?
Hello, sir. Yes, sir.
Are you asleep?
No, sir.
Fell asleep?
No.
You are hearing it?
Yes, sir.
കേൾക്കാമായിരുന്നോ ഞാൻ പറയുന്നത്? അതോ ഞാൻ വെറുതെ ഇങ്ങനെ, ഞാൻ ആക്ച്വലി സ്ക്രീൻ ഷെയറിംഗ് ആയതുകൊണ്ട് എനിക്ക് നിങ്ങളുടെ ആരും ഫേസ് ഒന്നും കാണാമല്ല, എന്റെ വീഡിയോ ഇടാൻ പറ്റില്ല. സ്ക്രീൻ ഷെയറിംഗ് ആ വെച്ചിരിക്കുന്നത്. ഹലോ,
Yes, sir.
സ്ക്രീൻ കാണാവോ?
Yes, sir.
So I was asking, which is the abductor of hip?
Gluteus.
Which gluteus? Medius. Not maximus. Not maximus. Okay, gluteus medius and minimus. These are the two strong abductors of the hip. So when there is a fracture of the shaft of femur, what happens is that the abductor contracts because of the unopposed action of the abductors. What will happen? The proximal fragment goes into abduction. Not only abduction, Because of the action of iliopsoas, it also goes into flexion. Okay. And the distal fragment goes into adduction. Distal shaft of the femur fragment goes into adduction because of the action of the adductor magnus. Okay. So this is the pathoanatomy. Why I am saying this is that most of the femoral shaft fractures are cannot be treated conservatively because of the unopposed muscle action. Even if we are keeping the fragment in alignment, it will again redisplace because of the action of these muscles. The adductors will pull the distal fragment to the into adduction, and the abductors will pull the proximal fragment into abduction in opposite directions. So most of the femoral shaft fractures should be treated nowadays, not in olden days. Nowadays should be treated operatively. So what are the types of femoral shaft fractures? As you know, the fractures can be classified into simple and compound. In femoral shaft fractures also there is simple and compound fracture. Simple fracture means the fracture is not communicating with the exterior, because that means there is no break in the skin. The skin and surrounding structures are intact, only there is a fracture. Or sometimes there may be a closed muscle injury also, but the fracture is not communicating with the surrounding environment. And compound fracture means here it is usually occurs in RTS. Here the skin and everything is broken, muscle is tied up, and the fracture actually comes out. So it is communicating with the external environment. There will be a lot of mud and also dirt in it. So that is compound fracture. Whether it is compound or simple, these split into different according to the pattern of the fracture, different type. Simple transverse fracture or spiral fractures, segmental fractures. So you can see the pictures of segmental fracture. Here in the fourth picture, you can see the femur is fractured into 3 pieces. That is called a segmental fracture. So if more than 2 pieces, one bone is fractured into more than 2 or 3 pieces, it is called segmental fracture. Comminuted fracture is that at one particular point of the bone is shattered. So that is comminuted fracture. You can see the picture of a spiral fracture, a oblique fracture, a comminuted fracture, and segmental fracture, and an open fracture. All these fractures are given in that picture. Okay, so these are the type of fractures. Now we come to the treatment part of the femoral shaft fractures. You see, in olden days, and there were no operative methods not available. Actually, after the Second World War, the operative methods become popular. Before that, during the First World War, a lot of patients died from femur fractures only, because femur is a large bone. It contains a large marrow cavity, and when it is fractured, especially in open fracture, there will be tremendous bleeding. Minimum 1 to 1.5 or 2, sometimes 2.5, 3 liter blood is lost. So there is every chance that there will be a hemorrhagic shock. Incidence of hemorrhagic shock is very, very high. So actually operative orthopedics comes to an establishment after the it began in this First World War, but after the Second World War. So before that time, almost all the femoral fractures were treated conservatively. How conservatively? So it can be, for example, in children, for example, in infants, 1 to 2 years of age, we can give traction only. This traction is called gallows traction. Gallows traction, we will suspend both the leg in a gallows. So that I will show the picture. Gallows traction, we apply gallows traction in case of infant fractures, infant shaft of femur fracture, infant or 1 to 2 year of childhood, that age we use gallows traction. And sometimes in up to 16 years of age, if the fracture is not that much displaced, we can use skeletal traction or skin traction. So that I will show in the next picture. You can see it is a picture of gallows traction. Here the child is having a shaft of femur fracture, and in order to get alignment, we are actually suspending the both legs in 90 degree. Hip is flexed 90 degree, and it it is attached to skin traction and attached to pulleys. We will apply traction over the pulley so that both the fragments will come into alignment. This is called gallows traction. GALLOWS, gallows traction. Next is, you can see skin traction and skeletal traction. In the first picture, we are actually showing skin traction. Here, we are applying a bandage around the lower part of the leg and applying traction along that, and put some weight over the traction so that we are actually trying to align the fractured fragments. And actually in femur fractures, skin traction is not that much effective. Skeletal traction, in skeletal traction, we can give more weight. Up to 10 kilos of weight we can hang in skeletal traction. Here in the second picture, we can see a skeletal traction. Here we are actually drive a pin through the proximal part of the tibia and hanging it with the help of ball stirrup that you can see in the ward. So this is called skeletal traction. So these are conservative method of treatment, but nowadays skeletal traction is also used in our ward because there will be a delay in surgery. We usually do surgeries after 1 week or 2 weeks because of the heavy load of patients. So by the meantime, we use a skeletal traction in order to keep the fracture fragments in alignment and to reduce the pain. When we give a traction, the pain will automatically get reduced and the fracture will get aligned and there will be muscle relaxation. In order to give that, before operation also we give skeletal traction. And sometimes we give plasters, hip spica. That is usually done in case of children. This is also a conservative method of treatment. Here, after giving traction and keeping the fracture fragment in alignment, we are giving a plaster. Look at the plaster. It covers almost the lower part of the body and both the leg. So this is a cumbersome fraction, and actually this is very difficult for the patient because they have to keep the hip spica for at least 1.5 to 2 months. They have to lay like that. So that is a very difficult thing. So here, in order to immobilize the fracture fragment, we are giving hip spica. This is the picture of hip spica. Here, we should cover the lower part of the body also in order to immobilize the hip joint. Now come to the surgical part. So conservative method of treatment, I have told you 4 things. One is in children, infants we give gallows traction, and children above 1 year or 2 year of age, up to 10 year of age, we can give hip spica. And in older patients, we can give skin traction and skeletal traction. These are the conservative method of treatment. But nowadays, most of the patients after the age of 10 or 15, we give open reduction and internal fixation. Open reduction and internal fixation. Hello, can you hear me?
Yes, sir.
Okay. So the operative methods are 2 types. One is external fixation, and the other is open reduction and internal fixation. In external fixation, even though it is an operative procedure, here we are not opening the fracture site. It is already open because external fixation usually we do in case of what, Abdullah? I know only you, that is why I am asking you.
Yes, sir.
Anybody? This external fixation is usually done in case of what type of fractures?
Comminuted fracture.
Not comminuted. Comminuted means the bone is shattered. External fixation is done. Anybody else? Can you answer?
Fracture.
Hello? Tell me. Hello? Okay, tell me. What type of fractures we give external fixation? Actually, a class should be a pedagogical one. There should be interaction from you also. Here I am just blabbering, and you people, I don't know whether you are listening or not. And somebody, can you respond? This is actually a preliminary orthopedics. External fixation is given in which type of fracture? Anybody? Open fractures. Okay. Any open fractures? Any fracture which is communicating with the exterior, if we go for operative reduction, we will give external fixation. Here we are fixing the fracture externally. As you can see in the picture, here we are driving some pins into the shaft of the femur and fixing it externally with the help of a device. Fixing it outside the body with the help of a device. This is, and Elisaro fixator is also a type of external fixator. It is called a ring fixator. So we can give either Elisaro fixator or a railroad fixator like this. Okay, so why we are giving external fixation in case of open fractures? Suppose if we are giving internal fixation, if we are putting some implants inside our body, what can happen? Due to the contamination of the wound, there is every chance that there can be a severe infection. So we may not be able to deal that infection at that time. So that is why at first we will give external fixation, and we will by giving external fixation, we can dress the wound very easily. We can daily dress the wound, we can daily debride the wound, and once the infection subsides, once everything is clear, we can remove the external fixator and do a proper internal fixation. So that is why we give external fixation. Okay, that is we give external fixation. So in closed fractures, we can do so many methods are there. We can fix the fracture by using LCP and DCPs. What is LCP and DCP? DCP means dynamic compression plate. You can see in that picture, DCP. There is a plate with so many holes. That is called DCP. So that we keep the, after reduction of the fragment, we keep the dynamic compression plate over the bone and fix it with screws. That is called dynamic compression plating or LCP, locking compression plate. Both are somewhat same. And another method of fixation is we can fix the fracture intramedullary. So intramedullary we can fix the fracture. So we can drive some device or nail through the medullary cavity of the femur. So we can fix it. This fixation is more stable than the DCP fixation, because in DCP fixation we are fixing the bone outside the on outside, and in intramedullary fixation we are fixing the bone internally. Here we are driving some nails internally into the medullary cavity, and one such device is that there is in that picture, that is called K nail. K nail is, that is the expansion is Kunstler's nail. Kunstler's nail. This nail we can, it is a clover leaf shaped nail. We can use this nail to fix femoral shaft fractures. It was used in olden days, but nowadays we are using interlocking nails. What is the peculiarity of interlocking nail? Interlocking nail is also a intramedullary device. Here what is happening is that we are actually locking the nail both proximally and distally by using screws, so that the nail will not move. For example, K nail, there is no interlocking is there. So what can happen? The K nail can move proximally. The K nail can migrate proximally. It can come out of the medullary canal. But here in the interlocking intramedullary nail, we are actually, after reducing the fracture, we are introducing the interlocking nail and fix it both proximally and distally with the help of screws. So it will become immobile. After the introduction of the nail will not move. This is another advantage of interlocking nail. Now, coming to the last part, what are the complications of the fracture shaft of the femur? So as I have already told you, shock is one of the important complications, because femur is large bone. There can be a loss of 1.5 to 2 liters of blood at a time. So there is a very chance that the patient can go into a hypovolemic shock. So if we are not attending it properly by blood transfusion and other measures, the patient can lose his life. And next important complication is fat embolism. Usually this fat embolism occurs 70 to 24 to, most commonly occurs within 24 to 72 hours, or it can occur up to 1 week. And most important period is the first 24 to 72 hours, fat embolism can occur. You know that the medullary cavity of femur contains lot of fat, marrow fat. This, due to the pressure, fracture when there is the pressure build up in the marrow cavity and the fat globules can driven into capillaries and that can ultimately reach into the lung capillaries. There can be blockage of the pulmonary vasculature and can cause fat embolism. This is a very dreaded complication. The within a span of few seconds, the patient can lose life if it is not properly attended. So how can you identify fat embolism? So if there is a femur fracture patient in your ward and he suddenly developed a spike of temperature and petechial rashes all over the body, then you have to definitely, and breathlessness. These are the important signs. There is sudden rise of temperature, breathlessness, and some petechials. Petechial rash may or may not be present. Petechial rashes over the body, then you have to suspect fat embolism and you have to immediately intubate the patient or ventilate the patient. So fat embolism is one of the dreaded complication. And as I have already told you, injury to femoral artery, femoral nerve, and sciatic nerve. These are another compound. So injury to vessels and nerves. Sciatic nerve can be injured because sciatic nerve is running in close relation with the posterior aspect of the femur. So it can be injured. Then infection. Infection is also because in case of compound fractures, there is every chance that there can be an infection. So infection can produce what? Osteomyelitis of the femur. So if there is an infection, it is a worse complication and the patient will be having it for his lifetime, most probably. He will actually live with that infection for long. It is very difficult to get rid of that infection. So infection is also a dreaded complication. And some complications are delayed complications. For example, delayed union. As the name implies, usually the femur fracture should heal within 3 months. But if femur is not healing within 3 months, even after 5 or 6 months, it is not healing and there is pain, we can say it is that we can say that it is due to delayed union. The union is delayed. It is due to so many factors. If the patient is diabetic or immunocompromised patient, the union is delayed. If there is interposition of muscles, the union is delayed. So if there is blood supply, there is comminuted fractures, severely comminuted fractures, there can be delayed union. So delayed union can occur in lot of conditions. And malunion, sometimes the bone unites, but what happens? It unites in a malunited position. There may be angulation and there may be shortening of the limb. So malunion is another delayed complication, and sometimes non-union. That is rare, but sometimes the bone may not unite at all. So what we can do, even after 9 months, the fracture is not uniting. But in non-union, there won't be any pain, but there will be undue mobility. The limb will be, the fracture site will be mobile. So for non-union, what we can do? We should again do the surgery and do some bone grafting. So these are the delayed complications. 3 delayed complications are there. One is delayed union, malunion, and non-union. And the other acute complications: shock, fat embolism, injury to femoral artery, injury to sciatic nerve, and infection. These are the acute complications. So this is it for now. Hello.
Yes, sir.
Can you hear me?
Yes, sir.
Okay, Abdullah, can you show your face? Hello. Okay. So what do you understand? Actually, did you get me? Were you able to hear it properly, or the
Yes.
class was a little bit problematic?
No, sir. It was clear, sir.
It was clear. Okay. So the thing is that you don't have to study in detail for your examination because you are only undergraduates. So only basic things you need know. What is the etiology? What are the causes? What are the pathophysiology? What are the types of the fracture or dislocation? And what are the clinical features? What X-ray you will do? And what is the treatment? And what is the complication? These are the things you should know when it is asked in exams. Okay. So hope everybody understood well. And if you have any doubt, you can ask me. Somebody, you have any doubts? Okay, I think that's it for today. Okay, thank you all.
Thank you,
Have a
sir.
good day. Have a nice day.
Thank you, sir.